Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle. September 13th is National Celiac Disease Awareness Day. So, in honor of that, we're going to shed a light on a condition that affects 1 in 100 people worldwide, many of whom remain undiagnosed. We are thrilled to have three of our leading gastroenterologists, Dr. Abhijit Bhatia, Dr. Jose Peragano, and Dr. Dana Sloan. They're here to share their insights and answer your questions. So thank you for joining. Give us a like. Let us know you're watching. Ask your questions in the comments below. And help us raise awareness of celiac disease. We're going to talk today about some myths. We're going to share important facts that everyone should know. So whether you have celiac, someone that you love has celiac disease, or you just want to know more, then stick around and ask your questions in the comments. Before we get into the questions that we have today, let's meet our experts. We'll start with Dr. Bhatia.
Hi, thank you again, Karen. I think it's very important for us to talk about this topic, but I will introduce myself. My name is Abhijit Bhatia. I have been with MedStar for about 15 years. I trained in Virginia, and I work mainly out of Union Memorial, but I also have offices at Good Samaritan Hospital, Bel Air, and in Towson. So glad to be here.
Glad to have you. Thank you. Dr. Peragano.
Hi, Dr. Jose Perengo. Nice to meet everyone. Thanks for having us. I'm currently primarily located in the MedStar Annapolis location, but I did start my career with MedStar at Franklin Square in right at the beginning of COVID in 2020. Did my training at Cleveland Clinic and Michigan State. Celiac disease is definitely something I'm passionate about, and thanks for putting the time together to have this very useful talk to share with our patients and the rest of the public. As you've mentioned, celiac disease is probably more common than we think. We're just scratching the tip of the iceberg here, but thanks for having us.
Of course, thanks for being here. And Dr. Sloan.
Oh, hello, everybody. Thank you, Karen. I'm Dana Sloan. I am the chief for gastroenterology at Franklin Square, where I am primarily practicing. I've been with MedStar for just over 2 years. I've been in practice for 19. As Karen and Dr. Perengao mentioned, celiac disease is a common disorder. And even though there's one day out of the year reserved for celiac disease awareness, it's something that definitely impacts our patients on a daily basis. So we're happy to answer questions that you all may have. And thank you for having us.
Of course. So I'm going to start with a question. Maybe the simplest one that we're going to ask today. I'm not sure, but let's just start with what exactly is celiac disease and how does it differ from a gluten sensitivity or a wheat allergy?
So, celiac disease is a condition where an individual develops actual intestinal or gut injury when they eat gluten. So, gluten is a protein primarily found in products such as wheat, barley, rye. When gluten causes this injury to the lining of the intestine, this leads to symptoms such as gas and bloating, abdominal pain, diarrhea, but sometimes constipation and other kind of more non-specific symptoms like fatigue, headache, and weight loss. By contrast, gluten intolerance may mean that your body doesn't react well when you ingest gluten, but you don't have the intestinal injury that can lead to some of the other future complications, which we'll get into later. Wheat allergy is actually an antibody-driven response, wherein exposure to wheat will cause this typical release of histamines that you'd expect from other food allergies. So, facial swelling, rashes, hives, wheezing, congestion, symptoms that are definitely distinct from celiac disease.
All right. Thank you. Appreciate that overview. Dr. Bhatia, so what happens in the body when someone with celiac disease eats gluten?
So normally when somebody will ingest gluten, it goes into the small intestine, and eventually it will get broken down into smaller proteins called gluten peptides. They will go into the lining of the small intestine, and if you have the right genetic makeup and have celiac disease, this will trigger an inflammatory response. And that in itself is your own immune system causing damage to the lining of the intestine. Usually there are these projections called villi that help with absorption of nutrients. Over time, as you get more and more damage caused by your own immune system, these villi become damaged and you get something called villus atrophy. This will impair your ability to digest the nutrients and can lead to anemia, osteoporosis, other nutritional deficiencies. And it's important to realize that the damage happens even with a very small amount of gluten. It does not have to be a large amount that needs to be ingested. And again, the inflammation will also lead to the symptoms that Dr. Sloan had just mentioned with the pain, bloating, diarrhea, and osteoporosis and things.
Thank you for that. That was going to be my follow-up question in terms of the amount of gluten that is eaten. It sounds like it doesn't necessarily matter. Any amount could affect the small intestines. Is that correct?
Yeah, so first, there's a spectrum to the disease. So everybody may require a different amount, but in general, we try to minimize the amount. And that's why it's important to even minimize cross-contamination. To even small amounts of gluten may trigger symptoms in some patients.
Yep, thank you. I have a family member that was just recently diagnosed with celiac disease, and the cross-contamination has definitely been a challenge for her. Is there, other than ingesting gluten, and obviously cross-contamination if something is cooked in a non-gluten-free kitchen or using the same utensils, that cross-contamination could happen when you're ingesting. Is there any other way that you could get gluten? Could it even be like come from the air?
So there are patients who can have a reaction to flour, for example, but I'm not sure, the celiac disease part of it has to do through ingestion through the intestine. So it may be more of an allergy related to the wheat as opposed to true manifestation of celiac disease.
Makes sense. Thank you so much. Dr. Parengao, so we talked about what happens to the body. Dr. Bhatia mentioned your immune system. So is celiac disease an autoimmune disorder? And can you explain what that means?
Right. I think both Dr. Sloan and Dr. Bhatia had touched upon this briefly in their responses. But technically, if you break down, the wording autoimmune, meaning self-immune, right? So the implication of that is it's your own immune system that's mediating or causing the reactions, as Dr. Bhatia had sort of explained. So in this context, an autoimmune disorder essentially means that it's your own immune system causing the inflammation, causing all these inflammatory reactions, and causing the effects of celiac disease in the body, which will likely be discussed later on in this talk. I think one of the implications here, when it comes to celiac disease, and it might be touched on later, but there's definitely a well-acknowledged disease association between celiac disease and other autoimmune diseases that may be more, I guess, well-known, such as type 1 diabetes, thyroid disease, and for the pediatric patients, patients with Down syndrome. There's definitely a strong disease association between celiac disease and that as well, partially due to the genetic predispositions to those conditions.
All right, thank you so much. I have one more question, and we're already getting questions from our audience. Thank you so much. So I'm going to take those as well. But speaking of the autoimmune disorder part of it, is celiac disease hereditary?
Definitely, there's a strong argument to be made in terms of those genetic predispositions, specifically the ones that have been implicated in terms of celiac disease is something called HLA, or human leukocyte antigens. Those are genetic markers for potentially for celiac disease, specifically the markers called DQ2 and DQ8. Those genetic markers, if present, can strengthen a diagnosis of celiac disease in some difficult to diagnose patients, but also if there are family members. So Karen, this might have implications for you as well. They do recommend testing for first degree relatives of patients with celiac disease because the incidence can be as high as 10%.
Hmm.
So that's something to consider for for our listeners out there who may have, like you, um, relatives living with celiac.
Thank you very much. So we have some questions from Caitlin, Susie, and Jennifer. Some of them we are going to answer a little bit later in the discussion, so I'm going to hold on those. But I do want to ask about a question from Caitlin. Thank you for your question. Can someone speak to silent celiac? I hadn't heard of that before. Can you explain what that is?
Yeah, sure. I think I might be covering that a little bit
Okay.
in some of my responses. But silent celiac disease are patients who um, are diagnosed with celiac disease without the classic symptoms, and it might be diagnosed on the sole basis of an unexplained lab abnormality. It's silent in that way, because it doesn't necessarily declare itself until later on in this disease process.
Okay, yeah, thank you very much. That does um, transition nicely to the next question I had for you, which is about symptoms. Can you
Mhm.
talk about the more common symptoms, and are there any surprising ones that people might overlook?
Sure. Yeah. So the classic symptoms that I was alluding to earlier, the stuff that Dr. Bhatia and Dr. Sloan, we all probably read about in our textbooks in medical school. The symptoms of recurrent diarrhea, weight loss, abdominal pain. Those would be the classic symptoms associated with celiac disease, and definitely, if a patient presents with that, that should celiac disease should be something to be considered almost immediately. But to answer your question in terms of atypical presentations, believe it or not, bloating, which is something we hear a lot, can be the sole presentation of celiac disease. In fact, I've had a handful of patients I've diagnosed with celiac disease whose only presentation was bloating. So that would be something I would consider surprising. There are other patients with celiac disease who don't present with diarrhea, but instead actually present with constipation. I think Dr. Sloan had mentioned it earlier, but other atypical symptoms may include fatigue, brain fog. Um, some patients even have psychiatric symptoms as a manifestation of celiac disease. And I mentioned earlier, and labs alone, like certain vitamin deficiencies, such as iron deficiency, that's unexplained, vitamin B12, folate, all those can be manifestations of celiac disease as well. There's a rash associated with celiac disease called dermatitis herpetiformis. It's a very itchy vesicular type of rash that can be seen in some patients with celiac disease. It's not that common. I've probably only seen a couple of patients in my career with that presentation, but it's almost diagnostic of celiac disease when it's seen.
All right, thank you so much. Let's talk about diagnosis. How is celiac disease diagnosed, and what tests are typically done for that?
Yep, great question. So when you have someone who comes to you who have these symptoms, or the clinician is suspicious for celiac disease, the first non-invasive way to screen for it would be antibody testing, which is essentially blood work. So we would typically test for those antibodies to those breakdown products of wheat, the gluten associated proteins or peptides, and we already sort of established that celiac disease is an autoimmune disorder. So what those blood tests would be checking for would be whether the patient has those antibodies to to gluten or its components. That would be the first place to start. And if a patient were to have positive antibodies or positive screening tests, then the gold standard for diagnosis, which would follow that, would be an upper endoscopy, which all of us are able to do. So it would be a scope that goes down the mouth into the stomach, into the first part of the small bowel where celiac disease manifests, and we would take multiple biopsies in that region, and the changes associated with celiac disease, the presence of those immune cells, the lymphocytes would be seen by the pathologists when they examine those biopsies. But more importantly, and it has implications as well for the patient, would be that villus blunting. I think Dr. Bhatia had mentioned it. Essentially, villus blunting is when those finger-like projections in the small intestine, they're a useful adaptation because it increases the surface area for absorption. Over time with celiac disease, that blunting makes those villi a lot shorter. It reduces your surface area for absorption, resulting in that diarrhea malabsorption type of picture.
Thank you very much. And this, one of the questions that I was mentioning earlier was from Susie. It's related to diagnosis. She asked, what should the follow-up be after you're diagnosed, if any?
Yeah, that's great. So obviously, Dr. Sloan would probably talk about this later too, but obviously the only treatment for celiac disease is to avoid the insult, which is gluten. So you're gonna cut, the assumption is you're gonna cut out gluten from your diet for the rest of your life in conjunction with your gastroenterologist and nutritionist. And the follow-up should be, if especially for a patient who had positive antibodies at diagnosis, you would check those antibodies at a certain point in time after going on a gluten-free diet. Typically, the current literature says, at the 6-month mark after eliminating gluten, the antibodies should completely disappear. So definitely at the 6-month mark, repeat those antibodies, and ideally should be negative. And depending on your presentation as well, you would probably want to repeat your upper endoscopy to document histologic response to the gluten-free diet as well.
All right, thank you very much. And yeah, we'll talk more about diet a little bit later with Dr. Sloan. Looking at symptoms, is it true that some people with celiac disease have no symptoms at all? Is that possible? Is that the silent celiac we were just talking about earlier, or is that different?
Yeah, exactly.
Okay.
I think the silent part of that name comes from the fact that it's clinically silent, so the patient may not have any symptoms at all, and that's also something that we've seen in our practice. The patients who come in have had the whole 9-yard workup for iron deficiency anemia, nothing's found, and we check their celiac titers, and lo and behold, their celiac titers are through the roof, and that alone could be their sole manifestation. The proposed mechanisms for that to occur is that the onset of celiac disease in those individuals could have been very insidious, that they've learned to adapt in terms of their clinical picture, and it's just the malabsorption that's sort of persisted and come to light, when their doctors order routine blood tests.
All right, thank you. So some of our viewers might be thinking, I have bloating, I have fatigue, I might have celiac disease. Can you talk, and they might be thinking, I should start going on a gluten-free diet now before I even get tested. Can you talk about the risks of doing that, of going gluten-free before you're tested, and why that's a problem for your diagnosis?
Yeah, that's a great question, and it's something we've definitely encountered as well. So we have patients, and even not necessarily related to their diagnosis, but even mainstream media sort of picked up on gluten-free diets as a sort of fad diet for some people. but incidentally, it could be life-saving for patients with actual celiac disease. So to answer that question, it does present a little bit of a conundrum in terms of how we typically approach celiac disease. So we have had patients, come into the office, complaining of possible celiac disease, but they've already put themselves on a gluten-free diet. So that uh, the blood tests that I mentioned earlier could very likely come back falsely negative. As I discussed earlier, if you've been gluten-free for 6 months, chances are, even if you had true celiac disease, those antibodies would be falsely negative by the time you see us and have the blood tests. So in those patients, what's recommended, if they're willing to do a gluten challenge. So a gluten challenge essentially asks the patient to intentionally ingest gluten for at least 2 weeks, and the recommendation is at least 3 grams of gluten a day. So 3 grams of gluten is about, a slice of bread, a cup of pasta, things of that nature. But to do that for at least a couple of weeks, if they're okay and willing to continue, then you would do it for another 6 weeks, and then you check the antibodies. But if not, if they're unwilling to do that, because especially if they actually have celiac disease, obviously they're miserable when they get exposed to gluten. Um, for those patients, we can consider just proceeding directly to the endoscopy and taking biopsies. And then that also goes back to the utility of the genetic testing. The HLA DQ2 and DQ8 could be checked for those patients as well. Obviously supported by other things such as the biopsies. But the initial step is to see if they do gluten-free, is it to do that gluten challenge, but if not, we can proceed with the other modalities.
All right, thank you so much. That was a great overview of symptoms and diagnosis. We're going to shift gears and talk with Dr. Sloan about treatment and diet. But before we do, just wanted to thank again our viewers for participating. We have some great questions that have been coming through, so keep them coming. Share this with your friends and family. As I mentioned, it's Celiac Disease Awareness Month, and not a lot of education it's somewhat new, and we are wanting to share more about this disease and help those that are living with it as best we can. So speaking of that, Dr. Sloan, once someone is diagnosed, we talked about this a little bit, what does treatment look like, and is gluten-free diet really the only option?
So, as Dr. Parenga mentioned, really the primary and most important treatment for celiac is truly strict adherence to a gluten-free diet. As a newly diagnosed patient with celiac disease, you'll need to partner with your primary care provider, with your gastroenterologist, to identify a skilled, registered dietitian and nutritionist who can help, curate a meal plan for you. They can work with you on strategies in terms of not only preparing your own food, but how to shop and how to eat out safely. Unlike patients who simply have gluten intolerance, really close adherence to a completely gluten-free diet is really the most important factor for a patient with celiac to remain healthy over time.
All right, I'm sure that's pretty challenging. I know from experiences and talking with my family member, that is a big challenge. Can you talk about what some of those challenges are, especially when they're transitioning, and especially, and Caitlin was asking about the importance of, the cross-contamination. Talk through that for us.
Absolutely. So, this is having celiac is like living with diabetes or chronic kidney disease or any other chronic medical condition. And one of the biggest challenges can be simply learning to adapt one's lifestyle and diet to accommodate this gluten avoidance lifelong. It takes time and effort for patients with celiac to really acclimate to their new diets. I think it's important that patients who are, newly diagnosed or been diagnosed for years, to give themselves some grace. It can take some time to adapt to this new diet, this new reality. Another sometimes unforeseen challenge is that many products, to your point, Karen, that are marketed as gluten-free are in fact subject to gluten cross-contamination because they're either prepared in the same facilities or in the same pot, as something containing gluten. So again, learning how to shop, learning how to, be safe and avoid potentially problematic foods is a large part of the learning curve. I think it's also important to add that there are kind of dietary challenges that can be expensive, right? For some of these gluten-free foods, and they aren't always priced the same way, which I don't think is right. And it can be very isolating. It can be emotionally and socially isolating. You imagine, I have young ladies come into my office and they want to split a pizza with their friends or go out with friends, and it can be difficult, when you have to adhere to this, relatively strict gluten-free diet.
Yeah, and there's not a lot of options out there, especially for going out to eat. So yeah, a lot of that social life does also get affected. We do
I
have a
think, I
question.
think, oh, go ahead.
No, no, go ahead.
So I think that, restaurants, food manufacturers, et cetera, are becoming wise to this. And Dr. Perringal's point, there is a certain fad element to some of this, but I think that, especially in the US, we are coming to a more and more realization of what we owe patients with celiac disease, and having more options out there. Again, in the supermarket, in the restaurants, I think there is a growing awareness of what's needed.
Yeah, I agree. I've been seeing it more often, and I'm thanking the restaurants. Thank your restaurants who are doing a gluten-free option, so they can keep it going. Uh, Dr. Sloan, Amber had a question. Is there anything that you can take if you think you came into contact with gluten, or anything preventative that you could help decrease your symptoms?
The short answer is no. The longer answer is there are other kind of analogous conditions, like someone with lactose intolerance can take lactase enzyme, right? Or with maybe like an intolerance to certain fructans to take Beano. But unlike those kind of sugar intolerance corollaries, you remember that gluten is directly causing an inflammatory response in the gut. So the only real measure of prevention is avoidance. So there is not, unfortunately, any supplement, et cetera, that can be taken to offset that injury. The real solution is to avoid it in the first place.
All right. Can someone who has celiac, can they go into remission or outgrow the disease?
So, patients who have celiac, meaning they develop this, inflammatory injurious response to the lining of their gut, are not simply going to outgrow that condition. To Dr. Perringal's earlier point, patients who are successful in avoiding gluten may go into clinical remission. They will feel better, and they will have that antibody go away, and you'll even see that mucosal healing when you go back and you repeat their biopsies after they've been following that gluten-free diet. So patients can go into remission successfully, again, with close adherence to gluten elimination.
All right, thank you. And we talked about this a little bit earlier, but can you, for those that weren't watching for this answer, can you talk about the health consequences? So if you have celiac disease and you don't treat it properly, you don't take the guidelines seriously, what could happen?
So, a lot of times what we see in our practices is not so much that patients aren't taking it seriously, but they have difficulty. They struggle with finding those gluten-free food options. So the reasons that we take gluten restrictions so seriously, that there are potential health consequences from not adhering closely to this diet. Certain conditions related to malabsorption, as Dr. Bhatia mentioned, anemia, osteopenia, osteoporosis, which is bone loss, can be especially problematic for patients, men, women who have untreated celiac and continue to be exposed to gluten. Young women in particular may also experience issues with infertility. I've seen a couple women in my practice who've come in trying to conceive, happen to have some other GI issues, and the underlying condition is celiac disease. Although it's rare, I think it's important for patients with celiac to understand that they are also at increased lifetime risk of small bowel cancers, including lymphomas. So again, it's really critical to not just understand the guidelines, but to partner with your gastroenterologist, with your nutritionist, to develop a plan that will help you to avoid gluten and keep you safe and healthy.
Thank you so much, Dr. Sloan. Great information. I'm going to move to Dr. Bhatia now. We're going to talk more about myths and facts and current research that's out there. I have a couple other audience questions as well. But let's go back, Dr. Bhatia, to the gluten-free diets that we started talking about. What are some of the common myths that you hear when it comes to those diets, and what's the truth? What should our patients know?
Well, I think first of all, the gluten-free diet, there's a lot of things that are available now that were not available maybe 10 years ago. So we do need to understand that the things that are available in the stores often are not as nutritious. So they may contain increased amount of fat or sugar to try to get things to taste better. They often have less protein and fiber. So I think even though things are available, we still need to understand that they may not be as good as something that you may prepare at home. In terms of the diets themselves, it is good that there's more awareness out there. But I think, patients have to understand that what they may be making at home that's gluten-free is going to be different from what may be available outside at the store in terms of the quality of the food. Some of the other myths in general with celiac, people may think that this is something that's only seen in childhood. And it often is seen as childhood, I think partly because we're more aware and everybody's looking for that. But the disease may present later on in life, even in their 20s or 30s, when patients present with other symptoms. And it doesn't always present with GI symptoms, as we already discussed, and it may be a skin rash, or it may be unexplained osteoporosis or iron deficiency. And if patients become asymptomatic, say they were to do a gluten-free diet, that also does not equal to a diagnosis of celiac disease. Um, so I think it is very important for patients to be aware of the diet. I think it's going to be in collaboration with the nutritionist to figure out, all the things that contain gluten. So, for example, soy sauce has gluten. So if you go to a Chinese restaurant, you have to be asking for a gluten-free soy sauce, or some of the coatings on medications have gluten. So there may be very small traces of gluten that you may be finding that you may not be aware of. Um, so I think it is very, very important to kind of look for those things.
That's a really good point. I didn't even think about medications. Uh, yeah, because you think about the food that you really anything that you ingest, right? You want to make sure that they're gluten free. And we talked about the rise in gluten free products. There's a lot more options out there. Being mindful of what is being presented on the packages. Can you talk about what are your thoughts on whether that rise in products has helped or hurt people with celiac disease?
Well, I think there's two sides to that. So one is it has helped because there's more options available for patients. So in some sense, it has increased the adherence to the treatment course, which is the gluten-free diet. It also has helped with quality of life for the patients. It makes social situations easier for patients, so they don't, there's more options available with gluten-free foods outside. So there's not a lot of the social anxiety or isolation. But they are generally higher costs, and again, as I had mentioned, the quality of the food that's usually gluten-free may not be as good just because they contain increased fats and sugars. It also has led to somewhat of a misunderstanding in that people may think that gluten intolerance is same as celiac disease, whereas patients with celiac disease have to be um, much more acutely aware of any cross-contamination. So I think sometimes other people may not take it as seriously, thinking that this is just, something that doesn't cause any damage, whereas, untreated celiac can certainly lead to long-term complications.
All right, thank you so much. And then, is there any promising research happening right now in terms of a cure or new treatment options?
Yeah. So first, the good news about celiac is that, there's no medications that people have to take long term that have other potential side effects. The bad news is it is something that, has some implications for quality of life for the patients, just, being on the gluten-free diet. There is a lot of research happening in terms of celiac disease. And I think the things that they're looking at really would be to have some sort of a binder or something that would degrade the gluten before it actually can trigger the immune response. There's things that affect the permeability, meaning that it prevents the gluten byproducts from entering the small intestine itself. They can block enzymes. There's also looking at gut microbiome to see if there's things they can do to help with as much inflammation happening. At the current time, there is nothing else that has been approved for use for celiac disease, but there's certainly a lot of research. There was some medication that was in phase 2 or a few years ago, but unfortunately, it was not shown to be very beneficial and was not proceeded with further. But there is a lot of research, and I think there's very promising research happening.
Great. That's good to know. So, as I mentioned, we have additional questions from our audience. Thank you so much for asking. So I'm going to go through those next. I'm going to go back to you, Dr. Parangao, because we had some questions about symptoms and diagnosis. The first one's from Jennifer. She was asking, can you talk about whether there's any racial disparities in diagnosis or even treatment of celiac disease?
So based on the data that we have, it seems to correlate more obviously with populations who live in the wheat belt, right? So if you look at a lot of the data, original research for celiac disease actually originated from Italy, which makes sense, right? They consume a lot of wheat. So a lot of the data out there has, there's definitely a higher incidence, or perhaps they're checking for it more. But to answer that question, that's at least one among many in terms of the differences in terms of um, the the prevalence of celiac disease in certain ethnic populations. I missed the second part. Can you go over that?
That's okay. Yeah, no, you answered it. Yeah.
Okay. All right. Yeah. So that's so it's definitely, if you're interested in getting checked, that definitely puts you at a higher risk if you happen to have some Italian ancestry, for example. But there are, on the flip side of things, there are certain populations in whom celiac disease seems to be less likely. So, for example, in patients with Japanese descent or sub-Saharan Africa, it seems to be less common in those regions. But potentially, if you look at the diets, right? So it may be related to that as well. Japan is very much a rice-based population, so they consume much less wheat compared to the Western counterpart. So again, it's likely very much related to that. The exposure to the antigen or the offending agent is much higher in certain populations, but also going back to the genetic predispositions, it's the distribution of those genetic markers are likely higher in some populations as well.
Mhm. Thank you very much. Another question for you from Gail. Can you talk about mental health symptoms that someone with celiac, or just maybe focusing on not only the physical side, but the mental load that comes with being diagnosed with celiac disease?
Of course, there's actually a proposed biologic or neurochemical basis on patients with either mental health or even neuropsychiatric symptoms from celiac disease. It would likely be related to certain nutrient malabsorptions, as we discussed. B12, folate can be affected, and iron as well. And those may have some downstream implications for a patient's well-being overall. But the second part of your question, in terms of the mental load or the mental effects of carrying a diagnosis of celiac disease, obviously, first and foremost, things that you, especially if you're diagnosed later on in life, you may have had, for example, things that were very pleasurable to you in terms of things that you enjoyed eating. For example, I even had a patient, some time ago, who's sort of she called it her farewell meal, is to have some Chick-fil-A, the day before her endoscopy, before the disease was formally diagnosed. I think that alone can be quite a major adjustment. And I think going back to Dr. Sloan's point in terms of how one were to manage celiac disease once diagnosed, it's definitely a multidisciplinary approach involving not just us as the gastroenterologists who diagnose and help manage celiac disease, but primary care, would play a big role in that as well.
Yeah, makes sense. Thank you very much. Dr.
Course.
Sloan, I'm going to turn this question to you from Jenny. Can a woman develop celiac after a hysterectomy? So could a major change in hormones cause an effect?
To my knowledge, there isn't a direct correlation between those two things. But Dr. Bhatia's earlier point, we can diagnose celiac at pretty much any age or phase of life. I think my age record at this point is someone who was 73 who was diagnosed and it came in for anemia. So I would say, regardless of what you're going through in terms of perimenopausal status changes, other hormonal factors, pregnancy, what have you, if you're noticing a change, particularly pertaining to GI symptoms, get evaluated, because although I'm not sure of a correlation between those two things, celiac can crop up at any time of life.
Makes sense. Thank you very much. Dr. Bhatia, two questions for you. First one's from Caitlin. After the initial biopsy, how long can it take for your antibodies to go down after you start a gluten-free diet?
So as Dr. Parangao mentioned, usually 3 to 6 months, we should notice a decrease in the antibody titers. And that also should correlate with healing of the lining of the intestine.
All right. Yeah, thank you. So it takes some time. That's
Yes.
good. That's good to know. And then from Rhonda, if you're diagnosed with with the celiac gene, but the celiac disease marker was negative, does that mean you would have a gluten intolerance versus celiac disease?
So first, the genetic tests, when we run them, they give us a probability. They are not diagnostic for celiac disease. The markers for celiac disease themselves would be the inflammatory markers reflected in the antibodies. So people can have an elevated antibody titer, which just gives them some increased lifetime risk of developing celiac disease. But if they don't have any symptoms and they don't have the antibodies present, then really we would just monitor for any symptoms. We do not go back and necessarily redo the blood work. It just means that you're more susceptible, but it does not mean that you have celiac at this time.
All right. Thank you so much. So, Dr. Sloan, if there are folks watching that might suspect that they have celiac disease, what do you recommend as the first step?
First step for any patient who thinks they might have celiac is to talk with their primary care provider, make a plan to meet with the gastroenterologist. I think Dr. Parangam mentioned earlier, Dr. Bhatia, please don't try to go this alone and take it upon yourself to stop gluten. Seek help. We're all readily available, not only to run the necessary diagnostic tests, but to talk with you about what else is going on, what symptoms that you're having. So just don't try to go on your own to do that by yourself.
Yep, makes sense. Thank you so much. Dr. Parangao, are there certain questions that should be asked during your appointment, specific symptoms that you should keep track of?
Yeah, so I think the questions primarily relate to whether perhaps you'd be a candidate for testing. But in terms of symptoms, yeah, again, those the classic symptoms of diarrhea, recurrent diarrhea, unexplained recurrent diarrhea, um, uh, abdominal pain, bloating, all those things would be worthwhile to track, even for someone who's actually been diagnosed. Because if you present with those symptoms clinically prior to your diagnosis, you'd want to ideally see those symptoms abate over time as you embark on the gluten-free journey that you're about to take.
Thank you so much. And Dr. Bhatia, what is one piece of advice you could give someone who's newly diagnosed and feeling overwhelmed?
So first, I would
A lot of
validate.
that.
Yeah, I mean, I would say, it is overwhelming, and it's okay to feel overwhelmed. But there are so many resources available, and as has been said earlier, this is not a process for the patients to deal with alone. It's going to be a very collaborative process with the gastroenterologist, the nutritionist. There are apps to find gluten-free foods. There's Find Me, I think it's called Find Me Gluten Free. So there's so many resources available. So even though you've been diagnosed with something that is going to have a major impact on your quality of life, it is treatable, it's manageable, and there's a lot of things we can do to help you get through and get started on this journey.
Thank you so much. We really appreciate the three of you for joining us. We thank our viewers for watching and asking your questions. That's all the time that we have today. So if you found this to be helpful, tag someone in the comments. Again, share this with your friends and family. You never know who might be struggling with potential celiac disease. So we'll be looking forward to National Celiac Disease Awareness Day on the 12th. And if you would like any more information about celiac disease, or you would like to schedule an appointment, we will put a link in the comments. You can also call 833-218-3914. We'll put that in the comments as well. Thank you so much. Have a great rest of the day.